Good morning. My name is Sam Linhares, and I'm a general surgery resident, and I am joined by fellow residents Kurt Schultz and Liz Godfrey. Our faculty sponsor is Dr. Ira Leeds. Today, as part of the Residents Read Surgery Initiative, we will be discussing development of a comprehensive survey to assess key socio-ecological determinants of health. This was a paper published in Surgery in 2024. To start with some background, socio-ecological determinants of health, also known as SEDO, are associated with outcomes after surgery across many subspecialties. Historically, neighborhood-level indices have been used as a surrogate for patient-level SEDO status. Robust studies outside of the surgical literature have demonstrated that neighborhood-level indices do not adequately capture patient-level SEDO domains, and preliminary surgical research has supported this conclusion. In work from our mentor's prior group, the presence of at least two SEDO risk factors at the individual patient level were associated with a 3.4-fold increase in the odds of a postoperative complication. Smith et al. Aimed to develop and pilot test a comprehensive practical tool designed to measure key patient-reported SEDOs at all socio-ecological levels.
The first phase of study design was survey development. They started with a conceptual model development process in which the study team identified all the key SEDO concepts they wished to include in the final tool. They followed this with resource compilation, in which they collected all the validated survey tools and questions they could find that mapped back to the initial concepts of interest. They followed this with drafting an initial survey that included over 200 questions across 20 unique survey tools addressing 24 initial concepts. This proceeded to modified Delphi consensus voting, in which they identified omitted domains, determined which survey tools to include, and winnowed down the total number of questions involved. The second draft then went to a second round of modified Delphi consensus voting. This is their concept map, which demonstrates the 88 domains from their community level to the individual level mapped concepts. The second phase of study design was acceptability and feasibility testing. For post-survey development, they did not identify an acceptable validated post-survey to administer, so they designed their own with 12 questions across 12 domains of acceptability and feasibility. They then recruited and administered the SEDO 88 to project participants and analyzed the results. The final consensus-based tool, SEDO 88, used 88 questions to characterize 31 SEDO domains. 41 adults across 3 medical centers who underwent or were about to go colorectal surgery were recruited and completed SEDO 88 and its post-survey. Each post-survey question received a positive response from at least 65% of the participants, indicating an overall positive response to SEDO 88. Participants rated healthcare access as the most relevant domain to their health, measured by SEDO 88.
For teaching points of this study, SEDO 88 is a novel tool to inventory SEDO across diverse domains, which previously have been assessed using separate instruments. Overall, the tool was used positively by patient participants. Delphi consensus methodologies can be leveraged to integrate multiple stakeholders' perspectives into comprehensive conceptual models and their deliverables, like SEDO 88. As for criticisms of this work, patient-reported SEDO domains are inherently subjective. An individual may view their SEDO status more positively or negatively than an objective third-party assessor. Holistic risk assessment for SEDO in surgery may require a combination of neighborhood-level data and patient-reported elements, but more research is needed to elucidate the optimal methodology. SEDO 88 does not evaluate mental health or capture behavioral traits such as resiliency and self-efficacy, although data suggests that psychological risk factors impact surgical recovery. SEDO 88 has not been fully validated. Although using previously validated instruments has some advantages, adopting these elements outside their original context may change their validity. Thus, next steps of this work are to conduct rigorous psychometric tool validation, as well as evidence-based subscale and total scoring. Future research should assess the relationship between surgical outcomes and SEDO domains as measured by SEDO 88. Bottom line of this work by Smith et al. Is using consensus-based methodologies, SEDO 88 was created and found to be acceptable and feasible by colorectal surgery patients. Patient-level characterization of SEDO domains, which can be inventoried using tools like SEDO 88, is necessary to inform the design of multi-level interventions to address health inequities. Thank you.